Kia ora. This session is going to be reviewing the information we require from an ECG to help in the diagnosis of an acute myocardial infarction. While the main focus may be around the ST segment elevation, there are some other indications that might assist when we're dealing with patients who are having a non-STEMI event. During the acute phase of a myocardial infarction, the early ECG changes are going to reflect alterations to the area of the heart muscle starved of oxygen and is possibly dying. The first changes we will see are going to occur during what we think of as the repolarization phase on an ECG complex. In other words, we're looking for changes to the ST segment and or the T wave. The second point I want to make is that the leads closest to the affected area are going to be the ones that we're going to see these changes in. So we need to know two things. Number one, which leads are used to identify which areas of the heart? And secondly, what changes we're looking for to let us know that damage is actually occurring. So to respond to the first point above, we need to think about groups of leads and which groups are associated with which anatomical area of the heart. For instance, which other leads would you automatically think of if you were presented with a change in lead AVF? Now you can test yourself with the following MCQ to make sure you've got this correct. The inference is clinicians must investigate any change in an individual lead alongside the remainder of the leads that are in that group, otherwise known as congruent leads. When presented with an ECG, we should learn to read the ECG by the lead groups rather than just making our way around the ECG in a clockwise or whatever fashion. To respond to the second point above, we need to know what are the hallmark changes that occur during ischemia, infarction, and tissue death. Obvious change that signals infarction is ST segment elevation. Once this elevation is seen in two or more congruent leads, clinicians must suspect that they're looking at a STEMI. Now, the damage caused by an acute myocardial infarction affects the repolarization characteristics of the area that's been damaged. The ST segment will rise above the baseline for the leads that are closest to this damage. Once seen in two or more congruent leads, it's likely that you are looking at an ST elevation myocardial infarction. Any electrodes on the opposite side of the heart will see the same event, but it's going to show them in a mirror-like fashion. That is to say, the ST segment will appear to move in the opposite direction, or more simply stated, it's going to move below the baseline instead of above it. This mirror-like movement is known as a reciprocal change. Now, from a diagnostic point of view, this is brilliant. If you see ST segment elevation in two or more leads in a single group, and then see reciprocal changes in the opposing leads, the chances of this being a ST elevation MI are even greater. Looking at this ECG here, the ST segment elevation can be clearly seen in leads 2, 3, and AVF, aka the inferior leads. So we would think we have ST segment elevation in two or more congruent leads that are in one group, so we think this is going to be an inferior infarction. What we can also see on this ECG is that this ST segment depression in leads 1, AVL, and clearly also in V6, aka the lateral leads, or the ones that are anatomically opposite the inferior ones. So what we're seeing then is the reciprocal changes. Let's take a closer look at this. The ST segment elevation in the inferior leads is clear, as is the ST segment depression in the leads that are anatomically opposite these. The learning point here is that clinicians need to be clear about what lead groupings they can see the ST segment elevation in, and which groups they should be using to check to see if there's these reciprocal changes. Now for this we can use the mnemonic PALE. So the opposing sides, those that are anatomically opposite each other are firstly the posterior and the anterior surfaces. So they would be said to be reciprocal to each other. The others are the inferior and the lateral surfaces. As we saw in the previous ECG, they are also anatomically opposite to each other. So making this a bit more straightforward, a change we see in leads 2, 3 or AVF, those inferior leads, are likely to be reciprocated in the lateral leads such as leads 1, AVL and or V5 and V6. The opposite is equally true. If the MI occurs in the lateral leads, we might see the reciprocal changes in the inferior leads. Now, should the ST segment elevation occur in the anterior leads, that is between V2 and V5, we'd expect to see the reciprocal changes in the posterior leads, such as V7, 8 or 9, even though we don't take these regularly. So, let's just recap briefly. The hallmark for myocardial infarction is ST segment elevation. If this is reciprocated in the opposing leads, then the diagnosis is even more likely to be correct. So before we go on and practice the skills associated with finding ST segment elevation, there's a few more pointers we should go through that are going to help with the ECG diagnosis of either a STEMI or a non-STEMI overall. Myocardial infarctions are not an instantaneous event. The process is one of evolution, and it's going to be over the first few minutes, then the first few hours, days, weeks, and eventually months. And each of these timeframes has specific ECG changes associated with it. The first event following the occlusion of a coronary artery is ischemia. And if we were to take an ECG tracing on someone just starting to have their myocardial infarction, the ECG changes we're going to see are those that are associated with ischemia, but not necessarily infarction. So instead of seeing ST segment elevation in the first few minutes, what we may see instead is tall T waves in the affected limbs. As the ischemia evolves into infarction, it's these same leads that will eventually show the ST segment elevation that we associate with the STEMI. So typically, the first few minutes of an acute myocardial infarction is going to produce T wave amplitude increases. That is, the T wave is going to be taller, it's going to appear wide, and the tip of the T wave is going to have a more of a rounded rather than a peaky appearance. Now, under normal circumstances, T waves in the limb leads should measure less than 5 millimeters. And for the precordial or the anterior leads, those V leads, it should be less than 10 millimeters in height. Another rule of thumb to look at is whether the T wave is 50% or greater of the preceding R wave. Now, if this is the case, or they do exceed the 5 or the 10 millimeters, and we encounter this in the setting of cardiac chest pain, the assumption should be the early phase of an acute AMI until this is proven false. The easiest way to prove this false is to take serial ECGs if the life pack itself is not recognising ST elevation and starting to print out the 12 leads under its own volition. An AMI that does not involve the full thickness of the myocardium, that is, it's not a transmural AMI, is unlikely to produce these ST segment elevations or the hyperacute T waves. However, even if the infarction is only a partial thickness event, it's still going to alter the repolarization characteristics of the tissue that's been affected. What this can result in is a flipped T wave. What's meant by a flipped T wave is a T wave that has been inverted or become negative. That is, it's going to be below the baseline. So in adults, the T wave should be upright. That is to say, it should be positive in lead 1, 2, and between leads V3 and V6. Now, while inversion in the other leads might be expected, leads 1, V1 and AVR are more likely to have inverted T waves under normal circumstances. So what we would be worried about is the presence of inverted T waves in the leads where we would normally expect them to be positive. The first of the examples we're showing here has inverted T waves in lead 2. We'd normally expect those to be positive, so already we should be worried. The other worrying factor is the relative size of the T waves to the QRS complexes. When I also investigate the rest of the group, that's lead 3 and AVF, they also have deeply inverted T waves. So we would note these as quite a worrying finding. You might also notice that there appears to be hyperacute T waves in lead 1 and in AVL, but the ST segment hasn't been affected. These are likely to be reciprocal changes to the inferior MI by these deeply inverted T waves. This second example has a particular type of T wave change. Leads V2 and V3 have biphasic T waves where the terminal section of the T wave is negative. This is called Wellen sign. It's associated with Wellen syndrome, which is a repolarization variant caused by a reperfusion injury. The theory behind this is that when there's been an incomplete obstruction of a coronary artery, it's possible for blood flow to the affected area to alter. So sometimes there may be more, sometimes there may be less. In these cases, the non-STEMI changes, such as deeply inverted T waves, may occur when the blood flow is severely obstructed. Should the obstruction lessen and some blood flow be re-established to the damaged area, the reintroduction of oxygen to the damaged tissue can cause a secondary injury that results in these repolarization changes. And this is where we see the persistent inverted T waves or the biphasic T waves in V2 or V3. Wellen sign can have two types. There's type A and there's type B. Type A, where we see these biphasic T waves with the terminal section being negative, or we see the type B ones which have the deeply inverted T waves present in both V2 and V3. ST segment depression is another common finding in a non-STEMI. It is far less predictable for the diagnosis of an AMI than what a ST segment elevation presentation is. However, it should still raise the level of suspicion for AMI when seen. The provisional diagnosis for ST segment depression is broad, and it can be caused by ventricular enlargement, pulmonary hypertension, some drugs that will do it, or there may be mechanical strain in the heart, say in the setting of heart failure. Now, these examples are more likely to produce an asymmetrical form of ST segment depression that slopes upwards towards the T wave, as can be seen on the left here. So, clinicians view a symmetrical or downsloping ST segment with depression as more worrying and likely to be a result of ischemia or a non-STEMI. ST segment depression that does not localize, that is, it won't stick to a single lead group, is more likely to be due to global ischemia. So again, localized findings that have horizontal or downward sloping ST segment depression are more worrying in terms of the fact that they're more likely to point to a non-STEMI. The last point I want to make around this is, should the ST segment depression exceed more than 1 millimeter over a couple of leads, the prognosis for the patient worsens. And if it exceeds 2 millimeters in 3 or more leads, it's highly indicative of non-STEMI and worse outcomes. Another subtle sign of a non-STEMI is where there's late or delayed precordial R-wave progression. Under normal circumstances, the R wave becomes progressively larger, starting at V1 and making its way through to V6, where it would normally be the largest. It should be the same height or taller than the S wave, somewhere between V2 and V4. So late or poor progression is when the R wave is still smaller than the S wave in V4. There are a number of reasons that this might occur, but one of them, particularly in the setting of chest pain, is that it's a subtle sign of an anterior AMI. The other extreme in the evolution of acute myocardial infarction is permanent tissue death and scarring. The long-term changes that affect the ventricular depolarization result in Q waves if there's been a transmural or a full-thickness myocardial infarction. Q waves exist when the first QRS deflection is negative. So any evidence of the first deflection of the QRS being positive, regardless of how small that deflection is going to negate the presence of a Q wave. When they are present, pathological Q waves represent the altered depolarization of tissue following an infarction. We expect to see these changes hours or even days following a myocardial infarction. Once they're formed, they may take months to resolve, and in some cases, they become a permanent fixture for people's ECGs. So, as a rule of thumb, Q waves will indicate previous damage, and as with ST segment elevation, they're going to localize and will appear on the leads closest to where the scar tissue is formed. So it's pretty easy to pinpoint the general location of a previous AMI if Q waves are present. The ECG shown here has Q waves in lead 2, 3, and AVF. Now there's also ST elevation in each of these leads, and it may well be that the AMI is still relatively acute and maybe only hours old. The Q wave in lead 2 is small. However, I decided to follow my own advice here and have inspected the other leads in the same group. So I found the Q waves greater than 2 millimeters in both leads 3 and AVF. We can see the ST segment elevation in the same leads, and if we were to look at the reciprocal leads, that is 1 and AVF, we can find there's a hint of ST depression in lead 1, but it is relatively obvious in lead AVL. So this brings us to the end of this very fast recap around the ECG changes that we would expect to find when there's been an AMI. So we know when there's been a STEMI, the first changes we're going to see are likely to be ischemic and produce hyperacute T waves. As the AMI evolves, there will be ST segment elevation, and the continuing evolution in these transmural AMIs is going to produce Q waves in the same lead. We know that the ST segment elevation is going to localize to the lead group closest to the damage, and that there may be reciprocal changes in the opposing leads. When it comes to non-STEMI, there can be a constellation of subtle signs which may not even be present. So if the myocardial infarction is not transmural, that is, the infarction doesn't involve the entire thickness of the myocardial wall, we may see things such as inverted T waves, we may see this poor R wave progression, and there may also be the suspicious ST depression where it appears localized as either horizontal or down sloping from the QRS, and where it's seen in 3 or more leads and is greater than 2 millimeters has a poor prognosis. I hope this has been of some value in terms of being able to review all the changes. I'll leave you to read through the rest of the material in Moodle around this. And as ever, if you've got any questions, don't hesitate to drop me a line. Ka kite.